Good morning. I'm pleased to introduce our first speaker of the day, Dr. Saul Jacobs. Dr. Jacobs graduated from Emory University School of Medicine and completed his internal medicine residency at Boston Medical Center. He then completed his endocrinology fellowship at Tufts and started his career at Emory in 1995. He is the section chief of the endocrinology unit at Emory University Hospital Midtown, and we're pleased to have him here today to speak on thyroid cancer diagnosis and first steps.
Good morning. I'm Saul Jacobs, endocrine at the Emory Clinic. Welcome to our Thyroid Cancer Symposium, and we have a great program planned for you today. I'll be kicking off the talks with a discussion of thyroid cancer, considerations in the diagnosis and initial management, with a focus primarily on lower risk lesions. I have no conflicts of interest or duality of interest. Today we'll look to understand the evolving epidemiology of thyroid cancer in the United States. We'll look to understand the implications of NIFTP when we see this on surgical pathology, as well as understand the considerations for the initial management strategies of thyroid cancer with a focus on low risk and what we call active surveillance. So this is data in some form we've probably all seen. Take-home messages here are primarily that for all comers, the risk of disease-specific mortality in thyroid cancer is very low. We can see that over the last decades, the incidence of thyroid cancer has risen significantly, but of importance is the upside-down triangles at the bottom of this slide, showing that the mortality from thyroid cancer has remained not only very low, but flat over these decades, suggesting that at least a significant portion of the increased incidence of thyroid cancer diagnosis is related to detecting lower risk thyroid tumors or lower risk thyroid cancers. It's true, however, that this isn't the entire story. Over this time frame, the incidence of higher risk thyroid cancers at all stages has increased to a certain degree, as well as the incidence of poorly differentiated or undifferentiated thyroid cancers. However, thankfully, that second category remains extremely low from an overall percentage. Poorly differentiated or anaplastic making up probably 5% or less of the thyroid cancers we see. This is additional data just to show that the largest proportion by far of thyroid cancer diagnoses are in women in this country. Having said that, though, it's important to recognize that the other part of the story is if you're a man diagnosed with thyroid cancer, statistically, you're less likely to do as well. And so that dominance of detection in women is lost with respect to the risk of mortality. So why are we seeing more thyroid cancer diagnoses? Part of it is related to what we call incidentalomas, incidental finding of thyroid cancer when we're looking for something else. Perhaps vascular disease. We've all seen carotid ultrasound referrals where they've noted thyroid nodules on the ultrasound. Incidentally, I've seen MRI C-spines, as I'm sure we have, CT neck for other reasons, CT chest, depending on the read, and then PET scans. And I want to just note specifically for PET scans that and we do see a lot of these referrals for PET uptake in the thyroid, noted on PET scans done for surveillance of other cancers. The two things to keep in mind on PET scan, number one is it diffuse uptake or focal uptake in a nodule? Diffuse uptake is typically a benign finding in thyroiditis. And so one wants to have an anatomic correlate and see an ultrasound to compare. If there's discrete uptake in a nodule, then still you're looking at only about a 50% chance or a coin flip that this is a thyroid cancer. While it's true that PET uptake in the thyroid cancer does predict more aggressive behavior, it's still only about a 50% predictor of a thyroid cancer if there's uptake in a discrete nodule on PET. So you compare it to the ultrasound and you make a decision about next steps. So that's incidental findings on non-thyroid directed imaging. What about thyroid directed imaging, specifically ultrasounds? Here's an example of a study looking at the regional use in the United States of thyroid ultrasound. And what they found, which is not necessarily surprising, is that the regions that had a higher incidence or higher use of thyroid ultrasound had a higher incidence of detection of thyroid cancers. Many of these were low risk, and it turns out that a lot of them were in older patients greater than 65. These patients had multiple comorbid medical conditions, which may increase their risk of surgery and higher risk of treatment generally. And it's this type of data that's led to the call for cutting back or reducing the use of, quote, inappropriate thyroid ultrasound. Well, if we look at guidelines, there's a little bit of a paradox here, because what we're being told is that if we have a patient who we have a known thyroid nodule, perhaps incidentally noted as we just saw on the last slide, or a suspected thyroid nodule, maybe based on exam, we're supposed to get an ultrasound. This is tough because we've all been in this situation where we felt a bulbous lobe that may be related to Hashimoto's and turned out not to be a discrete nodule, or perhaps a gland that was diffusely enlarged and we didn't feel a discrete nodule. So our exams are certainly not perfect. I think that for non-endocrinologists, there's even less trust in the exam and concern that the physician may miss something. The ultrasound is then done. So what is likely going to be the case is we're going to continue to move towards tools that allow us to risk stratify which nodules we want to go ahead and biopsy. So we're going to be finding lots of thyroid nodules. We don't need to biopsy all of them. And we'll use our guidelines and risk tools on ultrasound interpretation to help us pick which nodules to biopsy. If we dig deeper, the other things that will statistically impact our diagnosis of thyroid cancer and the incidence in this country will be things like the guidelines with respect to what the recommendations are for biopsy, as well as, and we'll discuss this shortly, pathologic classification is if we're going to start seeing a change in how we interpret some of the pathology, which will cut back on the number of diagnoses of thyroid cancer. So are we plateauing? Perhaps. Two things may be contributing to the tendency to diagnose fewer thyroid cancers as we move forward. One is risk tools related to which nodules to biopsy. The ACR TIRADS guidelines, which we now use at Emory for interpretation of our thyroid ultrasounds, will ultimately recommend biopsying some of the larger lesions, and this will decrease the number of biopsies potentially. And in addition, what would have previously been labeled as a thyroid cancer, if it's now reclassified as a NIFTP will no longer be reported as thyroid cancer. That will impact our SEER data, for instance. Here's a notation in the SEER website telling us that as of January of 2021, NIFTP is no longer going to be reportable as a thyroid cancer. So what is NIFTP? Non-invasive follicular neoplasm with papillary-like nuclear features. This is a move to eliminate classifying a very low risk neoplasm as a cancer based on data that encapsulated follicular variant of papillary thyroid cancer, which is extraordinarily low risk for locoregional progression or recurrent disease, should be reclassified as a neoplasm, not a cancer. In 2016, an international group labeled this differently and eliminated the term cancer from this description. Since that time, the World Health Organization has gotten on board and included it in their classification, and professional societies are getting on board as well to support us. It's important to note that this diagnosis of NIFTP cannot be made on cytology, though this will have an impact on cytology in the sense that probably the Bethesda 3 category will ultimately be shown to have a lower risk of being a thyroid cancer, ultimately, if we're going to describe the pathology as NIFTP. And this can also not be made on frozen section. Reason being that the entire capsule and now the entire lesion really needs to be assessed by the pathologist so that we can confidently classify this as a non-cancer or a neoplasm and not a cancer, i.e. NIFTP. The idea here is that these lesions do not progress and do not put the patient at increased risk of problems moving forward. We're stating here that these are not thyroid cancers, essentially. There's a public-facing description on the ATA website describing these. We'll run through them. These lesions look like they're papillary cancer by their nuclear characteristics. However, they can't have high-risk features, and in particular, there can be no invasion of the capsule, no invasion of blood vessels or lymphatics. They're follicular lesions, and they can't have other high-risk pathologic features such as necrosis, high mitotic rate, or papillary architecture. In addition, they can't have any areas that look like different types of thyroid cancer, such as insular changes or tall cell changes. There's been further progress to address the diagnosis of these lesions with newer criteria with primary and secondary components. So whereas initially there could be a very small percentage of papillary features, now there can be no well-formed papillae, and there cannot be any of the features we discussed previously. There has to be clear demarcation of the entire capsule and no invasion noted. On review of the entire capsule, the entire tumor has to be reviewed to assure there's no papillae, no samama bodies, and no other high-risk features. In addition, there's a move to look at some molecular markers as well in these lesions to see if any of these mutations, such as TERT, for instance, changes risk. And this may be incorporated routinely for us to give us more confidence in this diagnosis. Ultimately, however, the idea is that the previously described low-risk cancer really does not increase the patient's risk. And if we can be sure that certain characteristics are not present on the surgical pathology, we can confidently label this as a NIFT-TP and follow the patients. There's evidence in the literature that the larger lesions in this category of NIFT-TP do not increase risk of local regional progression or morbidity, and these criteria seem to hold true for pediatric patients as well. There was a group from the 2015 Guidelines Committee that was tasked with reviewing recommendations with respect to NIFT-TP. They came back and published that they were still recommending that they be managed as low-risk lesions. So, for instance, lobectomy potentially acceptable, no I-131 acceptable. TSH does not need to be suppressed beyond 0.5 to 2.0. However, the interval and length of follow-up is not yet defined, and prospective studies are still needed for us to be clear on what the management entails. Having said that, the recommendation was to consider monitoring thyroglobulin and neck ultrasound in these patients. This is all relatively new. We're getting used to this and our decision-making for management here. What do I do personally? I do follow the patient's thyroglobulin. I understand that if the patient has part of their thyroid left, or if they've undergone a total thyroidectomy but have not had remnant ablation, the thyroglobulin is not going to be undetectable. I review this with the patient. And so if the thyroglobulin is, 6 or 10, as an example, and then on a recheck it's 90, I think that's helpful data. But we're not going to have thyroglobulins of 0 in patients who have remnants or even half their thyroid left in the neck. I continue to follow neck ultrasounds, and I will reclassify their risk as I would any thyroid cancer, but for now I'm following initially yearly, and I'm looking at the contralateral lobe, should that lobe still be in situ, and the neck, so cervical chains. With respect, so we'll leave NIFT-TP and talk about management strategy for low-risk lesions, but generally speaking, we're stratifying patients at not only at the time of diagnosis, but we're reclassifying risk in follow-up, the so-called dynamic paradigm that was described by Dr. Tuttle and his group. Remember that pathology, particularly in younger patients, is going to be your primary consideration and overall risk, because younger patients can't get more than a stage 2 even with distant disease. Reclassifying, or a dynamic strategy for risk classification, impacts our management both with respect to interval and duration of surveillance, for instance, neck ultrasound, and our goal TSH. So what is a strategy of active surveillance in patients who may have a low risk thyroid cancer, or who we think have thyroid cancer based on imaging characteristics on ultrasound of a nodule, but we want to consider not going directly to immediate surgery? And the decision-making here is really not surgery or not. The decision-making is immediate surgery or not. So we think about this generally without specifics related to nodules, just based on the patient. So if there's a very low risk patient or thyroid cancer, then it's not clear that if they weren't going to have a problem from the lesion anyway, that anything we do will help them. So if there's no benefit, it's all risk. Note that there's some caveats when you first assess the patient with respect to, let's say, small nodules that you think may be a thyroid cancer. On neck ultrasound, if the lesion's in a high-risk area, for instance, subcapsular adjacent to the recurrent laryngeal nerve, you want to be sure that you assess the entire neck. We've all seen patients who present with diffuse and extensive adenopathy but have microscopic or sub-centimeter lesions in the thyroid. These patients probably present this way. These are probably not patients who we find with a low-risk lesion and a clean neck and then develop extensive local regional disease. But the point is that you want to make your decision based not just on the thyroid, but on the neck. If there's a lesion in the thyroid, you want to be sure you've assessed the neck for adenopathy. I tell my patients it's not forget, it's follow. It's an active surveillance program. We follow these lesions to see if there's growth. And an important part of this is really patient preference. The patient has to obviously be involved in the decision making. If you've got a patient who's telling you they're going to go to surgery regardless, then this is not a patient that would be a good candidate for active surveillance. They may wind up just finding a different center to have the surgery done. And so their input at the beginning is critical. This all comes from data initially reported in Japan, where these small low-risk tumors that were felt not to progress were looked at and found over time to be safely followed. So since that time, we've had follow-up data to look and find that patients with low-risk lesions, small cancers that have been biopsied and shown to be papillary, if there's no evidence of disease in the neck otherwise, can be followed with a low risk of progression or development of adenopathy. It's not zero. Younger patients who have more time to be followed will be more likely to have progression. And so we have to keep a close eye on the patients and make sure they're not lost to follow-up. There's a U.S. experience as described in this study. Over 500 patients, they looked at lesions up to 2 centimeters in size and followed for 4 years. No nodal metastases were noted. About 3 to 4% of patients either did show growth or were converted to surgery for other reasons. The ATA does give us some guidance here with respect to active surveillance. Here is high suspicion on imaging characteristics without a biopsy. And they note that even though most nodules meeting concerning sonographic pattern criteria should undergo FNA, a conservative approach may be appropriate in selected patients, those with very low risk or small tumors, or patients at high surgical risk or short life expectancy. They also address patients who have positive cytology and consider active surveillance as an alternate to immediate surgery. These would be very low-risk tumors, microcarcinomas, or patients who are at high surgical risk or a short lifespan. And this is all in clinical context. So even before this whole paradigm of active surveillance, we were assessing patients with respect to medical comorbidities and surgical risk anyway. Patients who have high surgical risk from other medical conditions or cardiovascular risk, patients who have an ipsilateral cord injury from a previous hemithyroidectomy. These are patients who we have to decide whether the risk of a surgery outweighs the benefit. There are other reasons to take thyroids out as well. We're not just looking at a small thyroid cancer. If you've got a large tumor with or benign goiter with mass effect, if you've got obvious invasion, or the patient has obstructive symptomatology, or perhaps the patient has an autonomous nodulous suppressed TSH or a toxic nodular goiter. We'll be looking at other considerations in initial management, total versus hemithyroidectomy, completion thyroidectomy, neck dissection, I-131, external beam strategies, and systemic therapies for patients as their initial risk stratification later on this morning. So in summary then, We've looked at the epidemiology of thyroid cancer generally and how some of our new guidelines and classification is impacting that incidence and potential plateau as things progress. We've looked at the new classification of NIFTP and how that impacts our management of patients who are now not classified as having a thyroid cancer. And I meant to note that there is an ICD-10 code of thyroid neoplasm that you can use to get when you order your ultrasounds or see patients in follow-up, so that label of thyroid cancer is not on their printout. And we discussed the option of active surveillance in either very low risk thyroid cancers shown on cytology or in what we think may be imaging characteristics suggestive of small thyroid cancers on ultrasound. Thank you for your attention, and I look forward to the rest of the morning.